Right, I am Dr. Mina. I'm your co-host today. And today our topic of discussion is diagnosis and management of TTP, thrombotic trombocytopenic purpura. It's a very important topic. And we've got Dr. Lim Soo Min, who is a distinguished hematologist who's currently at Hospital Sultana Amina, Johor Bahru. Welcome, Dr. Lim. Thank you so much for being with us today. So it's all yours now.
Thank you, Dr. Mina. First of all, from us, hematology, this is our the last topic for the month of September. We really would like to express our gratitude to College of Physicians and also to the organizing committee for giving us opportunity to talk to everyone about some common hematological problems that may be faced by a general physician as well as the medical officer. We chose this topic because we think these are very related. In fact, if you ask me why TTP is important, I still remember when I was a physician back in Alostar. I remember the first case of TTP that I saw was a nursing sister who attended a course in Langkawi and became unwell. Fortunately, we make the diagnosis early enough and we send her off to Penang Hospital for urgent plasma exchange. And I heard she make a full recovery after that. And along my stay in JB, I've also encountered many cases of TTP that fortunately diagnosis is made early enough. So this is something that if you never ever thought of it, you will not even think of it. That is why we think that this talk is important to raise the awareness of TTP. Without a proper treatment, the mortality rate is so high. So we actually rely on the medical physician as well, the MOs out of the hospital with hematologists to make the early diagnosis and then refer to us. That is why it's so important. So to talk to us more on TTP, we have Dr. Gan Yiling to talk to us today. Now, Dr. Gan Yiling graduated from UM in 2008 and obtained her MRCP in 2013. She then underwent training in clinical hematologist and obtained her fellowship in clinical hematology in 2019. I remember she's such a good person that her colleague Dr. To told me when she was a physician in Hospital Penang, she's already so her performance is so outstanding that our head of services, Dr. Goh Isim, already earmarked her to do her hematology. I'm so glad that she eventually chose hematology, and she's now the consultant hematologist at Hospital Seremban. And she's also very active in doing research, and she was the part of the organizing committee for the previous year MSH. So without further ado, over to you, Yiling.
Afternoon, Dr. Lim. Yeah, hi. Thanks for the kind introduction. I would like to share my screen. Mina, I'm unable to share my screen.
Hang on, Dr. Gan.
Because you need to...
Can try now, okay.
Okay, thanks. Okay. Hi, afternoon, everyone. It's my honor today to be with everyone here and during the last week of the hematology webinar organized by the College of Physicians Malaysia. Okay. I'm honored to share with you the topic today, which is diagnosis and management of thrombotic thrombocytopenic purpura, which is also well known as TTP. Okay. Next slide. As far as I know, majority of the participants are actually our frontliner, which is our medical officer, physician from internal medicine. So I thought we go back to the basics and ask ourselves, what is the clinical and lab presentation of TTP? Do we have any assessment tools that can help us to differentiate the TTP from other disorders? Okay. So as we know that the differential list is so long, so can you briefly talk about the differential diagnosis of thrombotic thrombocytopenin purpura, and how do we treat DTP when we see a DTP case as a newly diagnosed case, and what should we do during the emergency setting? This is basically to reduce the mortality rate. Okay, when we talk about TTP, we can't avoid introducing you Dr. Elie Moskowitz, who is an American pathologist and physician. About 100 years ago in 1924, he published a paper called An Acute Febrile Pleochromic Anemia with Highline Thrombosis of Terminal Arterioles and Capillary, which is an undescribed case from the very beginning. Okay? So from the title itself, you can roughly guess that this patient has anemia as thrombosis. This is the first DTP case in the history, which was published. It happens in a hospital in New York City. Dr. Moskowitz noted that his patient, a very young 16-year-old girl, came in with anemia. They found that she has small and large bruises as well as microscopic hematuria, so they thought she is actually bleeding. She succumbed to her illness very quickly, and at autopsy, they found, however, although she's bleeding, they found disseminated microvascular thrombi. Okay. At the end of the articles, Dr. Moskowitz wrote there, from this observation, we concluded that the death in this very young patient resulted from some powerful poison, which had both agglutinative and hemolytic properties. This is the details of the case that Dr. Moskowitz described about 100 years ago in September 1924. On 5th of September, a very young girl who just spent her holiday with her family returning to home, and she developed fever. She had upper limb weakness, pain on moving the wrists and elbows. Only after about 9 days, she got herself admitted to hospital when her symptoms worsened, and she was admitted to hospital. She stayed in the hospital for about 6 days, and she died on day 6 of admission. On symptoms-wise, she developed partial paralysis of left arm and leg, slight facial paralysis, and she was found to have double clinic reflexes present. Examination revealed a very pale patient. They found left arm petechia on this patient, and other examination were insignificant. She's very anemic with a hemoglobin of 4, white cell mildly raised of 12.6, but platelet count was not done at that point in time. A red cell morphology revealed a central pallor with fragility tag showed hemolysis to begin very early at 0.8. Urea was 21 and creatinine was 1.1 milligram per deciliter. Chest X-ray was clear, blood culture were no growth. However, on day 6 of admission, she went into comatose condition and she died in a very short presentation of the illness. So what is the possible dangerous poison that Dr. Moskowitz mentioned that causing bleeding and thrombosis at the same time? Only after about 70 years, ADAM-TS13 was found and discovered in 1998. Okay, by the name, if you can look at the cartoon here, this is a short form for disintegrin and metalloproteinase, which is here, with the thrombospondin type 1 motif member 13. Okay? So it's an abbreviation for this enzyme. So from the name itself, we know that this is an enzyme cutting some proteins. Okay? So ADAM-TS13 is a zinc-dependent metalloprotease. It's being secreted in our body predominantly by the liver as an active enzyme. It has no natural inhibitors. It stays in our body for quite some time, for about 2 to 3 days, and ADAM-TS13 has highly specific function. It only cleaves von Willebrand factors at a single site, which is A2 domain. Essentially, the function is to regulate the size of the von Willebrand factors so that the von Willebrand factor is not too short, not too long, so that we are not bleeding, nor we are actually having thrombosis spontaneously. Let me show you some cartoon to describe further. In normal hemostasis, when you look at the cartoon on the left-hand side, upon activation of vascular injury, the endothelial cell will release the von Willebrand factors. Okay, so when these von Willebrand factors become very, very long and large, we call this ultra large von Willebrand factor, which is very hyperactive and is very sticky. In other words, it will attract platelets to come over to bind here and cause spontaneous aggregate platelets, resulting in systemic thrombosis. So the function of ADAMTS13 is in fact cut these ultra large von Willebrand factors. Okay. This is to reduce the size of the von Willebrand factor multimers in circulation, again to maintain the hemostatic function and abnormal platelet agglutination that happens in our body. Let's see some more pictures. So I was asking myself, so does ADAMTS13 cut the von Willebrand factors all the time? The answer is apparently no. Okay. In a normal situation, for example, in a very low shear stress condition, when we have not very, the blood flow is quite good in a large vessel, our von Willebrand factors remain in globular morphology. It will be partially unfolded or even fully unfolded when your shear stress is very high, in particular in very, very small vessels like arterioles or even venues. So when you open up the ultra-large von Willebrand factors, remember just now we said that ADAMTS13 cleave the von Willebrand factor at A2 domain. So when you expose the A2 domain, then here comes the ADAMTS to be playing the role for proteolysis of the von Willebrand factors. Okay, so this is another description. Probably we look at the left lower cartoon showing you the binding of platelets to von Willebrand factors. If you can notice here, it's actually through the yellow color circle, which is von Willebrand factor A1. So the binding of platelet to von Willebrand factor is through von Willebrand factor A1 domain through GB1B receptor on the platelets. Okay. So where is von Willebrand factor A2 domain? This is a blue color circle on the von Willebrand factors. If you look at the cartoon on your right hand side, okay, under low shear stress, the blue color circle, which is a von Willebrand factor A2 domain, is being hidden. So your ADAMTS13 cannot work only under high shear stress in a very small arterioles and venues. When you open up the ultra-large von Willebrand factors, the ADAMTS13 can come into play and cut the ultra-large von Willebrand factors at A2 domain. So this is how ADAMTS work in normal hemostasis. Okay. Okay, so we can roughly guess what if we do not have ADAMTS13. By definition, TTP thrombocytopenin purpura happens when we have severe ADAMTS13 deficiency. Okay, the keyword here is actually severe, activity of less than 10%. This is result from the IgG autoantibody towards ADAMTS13 enzyme. Okay. The picture on your right hand side describes the ultra-large von Willebrand factors, which is very sticky, very hyperactive. So when you don't have the enzyme to cut the ultra-large von Willebrand factor, it gets longer and longer. It attracts and activated all the platelets and cause platelet-rich clots in the musculovascular. And depending on the site of thrombosis, patient can come in with multiple clinical presentation. Okay. So by understanding what ADAMTS13 works, we can roughly know what is the clinical and lab presentation of TTP. Which is the first part of the talk. Okay. So more and more picture coming. I thought pictures paints 1,000 words. Okay. So the purple color represent the ultra-large von Willebrand factors. As when they are very hyperactive and sticky, they attract all of the platelets which are yellow in color. So they form the microthrombi here. So all the platelets are being used up. This will cause the first clinical presentation, which is thrombocytopenia. When you have thrombosis at the at microvessel, when the red cell is trying to flow through, it will cause red cell fragmentation. So you will have microangiopathic hemolytic anemia in TTP. As this is autoimmune diseases, patients most of the time have fever, but usually not the very high spiking fever with chills and rigor, but rather low-grade fever. And also depending on the site of thrombosis, we might have neurological manifestation as well as acute renal failure. The reason I put these 5 clinical presentation up is basically conventionally, historically, we describe TTP as pentat of thrombocytopenia, MAHA, fever, neurological deficit, and renal abnormality. After many, many years of TTP development and also the understanding of TTP, we realized that the pentat of TTP only happens in less than 10% of the patient. Okay. A lot of time, we might only see a patient with thrombocytopenia, MAHA, and neurological deficits. Sometimes we can have a TTP with thrombocytopenia and MAHA itself. What I mean is we do not need the pentat of all 5 symptoms to diagnose thrombotic thrombocytopenia purpura. This is a paper published from Milan TTP registry describing 17 years of case accumulation for all their TTP cases in Italy. The points that we wanted to make is that TTP is a multi-organ disease with variable clinical features. The blue bar represents the first event of TTP patient that they have seen in the registry. The red color bar represents the relapse cases of TTP. Let's see the blue color bar first. We understand that most of the patients, about 90%, presented with systemic symptoms in which they might come to you with fatigue, fever, abdominal pain, headache, jaundice, and vomiting. Basically, very non-specific symptom, almost 90% of patients, which is followed by bleeding tendency, about 70% of the case, with hematuria, mucosal bleeding, GI bleeding, petechiae in the purpura. Among all the end organ clinical manifestation, neurological manifestation rank about 60% of the case. Patient might come to us with stroke, seizure, coma, confusion, or even TIA. If you notice here, renal manifestation is only about 20% from this registry, presented as acute renal failure, anuria, proteinuria, hemoglobin, and oliguria. So again, this is not very predominantly happens in TTP if we are thinking about HUS as one of the differential diagnosis for TTP. Cardiovascular presentation, patient might came with chest pain with acute coronary symptoms, ECG, and ischemic changes. Okay. So what about relapse cases? Again, in relapse, most of the patient came in with bleeding tendency, followed by systemic symptoms, and then followed by neurological manifestation. In addition, I would say the renal presentation and cardiovascular presentation is rather rare in relapse. Okay, so this describes the clinical, the variable clinical features of TTP. So how we diagnose a TTP? We need to confirm there is MAHA and thrombocytopenia. It's also called as MAHA. So baseline full blood count is important to determine the level of anemia, to confirm the diagnosis of thrombocytopenia. Urgent review of the blood film to look for fragmented cell, or we call it cystocytes. The hemolytic markers need to be there to support our diagnosis of MAHA, evidenced by elevated lactic dehydrogenase, indirect hyperbilirubinemia, reticulocytosis. Low or undetectable haptoglobin is important as well in supporting the diagnosis of hemolytic anemia. So taking a good history and examination is important. This is basically for us to assess the target organ damage. Okay. We might consider cardiac enzyme, ECG, echo, kidney function as baseline, urinalysis, looking for proteinuria, hematuria, and neurological examination, CT scan, and imaging for neurological manifestation. If let's say we are unsure, let's say we see a case like TTP, but we do not know this is TTP, can we use prediction score to help us during acute setting? So when we talk about TTP, the tools that can help differentiate TTP from other disorders, we need to introduce to you the French and the Plasmid Score, which predict the likelihood of severe NTS13 deficiency in suspected TTP. Personally, I prefer Plasmid Score because it's very easy to remember. Plasmid, we have 7 components. It's actually an abbreviation for platelet, thrombocytopenia of less than 30, L for hemolysis, There is definition for that with more than 2.5% of reticulocytosis, undetectable haptoglobin, indirect bilirubin of more than 2, you will score 1. A for absence of active cancer, S for solid organ or even stem cell transplant, MCV for mean corpuscular volume or less than 90, I for INR of less than 1.5, C creatinine of less than 2 milligram per deciliter. So you will have minimum score of 0 and the maximum score of 7 to guide us about the likelihood of severe ADAMTS13 deficiency. A score of 6 to 7 indicate high risk, about 62 to 82% probability of TTP. French score is a bit more simple. They only take into account the platelet count as well as the creatinine, okay, with the background of confirmed MAHA and thrombocytopenia cases. And bear in mind that this scoring is being designed for adult population with no comorbidities, meaning that you cannot use in pregnant lady, cancer patient, stem cell transplant patient already known of, and we cannot use it in pediatric patient as well. Okay. Probably I suggest we use this scoring when you see to rule out TTP patient at middle of the night before you decide need plasma exchange or no need plasma exchange. So we use Plasmid Score. Again, we like to emphasize that TTP is a clinical diagnosis, a MAHA plus low platelets with or without organ damage, and we can't find alternative explanation is TTP until proven otherwise. Okay, so a MAHA plus thrombocytopenia. We do not need a pentype for diagnosis of TTP. And also, the use of a formal risk assessment model like the Plasmid Score, French score may support our clinical judgment in differential diagnosis. However, the clinical score do not replace the ADAMTS13 testing. We still need to send for ADAMTS13 testing. So what is the differential diagnosis of TTP? The list can be very long. As we know, TTP over here belongs to a group of blood disorder known as thrombotic microangiopathy. So it's also called TMA. From the name, we can guess that we have thrombosis. So TMA are characterized by widespread ischemic damage due to microthrombosis in the small vessel. Okay. Then again, thrombocytopenia due to platelet trapping, and MAHA secondary to red cell fragmentation. The three big group of TMAs consist of TTP, the atypical HUS, as well as stack HUS, which is a sugar toxin producing E. coli hemolytic uremic syndrome. So when we are talking about the differential diagnosis for TTP, right, basically we are talking about the differential diagnosis for TMA, where as I show you from the previous cartoon, so the main is the TTP. We have congenital TTP in which we have patient have mutation over the gene producing ADAMTS13. This is called cTTP, C for congenital. Those TTP, more than 95% of the cases of TTP that we are seeing are actually immune causes because of the IgG attacking the ADAMTS13, causing severe deficiency of ADAMTS. So we have HUS under another big group of TMA that we can remain one of the differential diagnosis. But bear in mind that HUS, most of the time they come in with very significant renal failure if compared to TTP. That's why in Plasmid Score, there's one score of creatinine less than 2 or 2.25, because most of the time the renal failure is not very, very severe. Okay. So in DIC, it's also a TMA, and the secondary TMA, the list can be very, very long. It can be malignant hypertension. In a pregnant lady, do not forget about HELLP syndrome, preeclampsia. Our SLE, APLS patient can have TMA, pancreatitis, infection like strep pneumonia, HIV, Hep C, malignancy, a systemic metastasis of malignancy can cause TMA. Medication that can cause TMA as well. Do not forget about solid organ and bone marrow stem cell transplant. And also these TMA, we have a lot of mimickers. For example, a B12 deficiency, you might have anemia, thrombocytopenia, and raised LDH. But when you see a B12 deficiency patient, they're usually rather stable and well, right? If compared to a very ill DDB patient. Then we have endocarditis sepsis to mimic TTP, Ivan syndrome with anemia as well as with autoimmune hemolytic anemia and thrombocytopenia, but the presence of direct Coombs test basically rule out a TTP. And other autoimmune disease as well can mimic a TTP. This is to make the situation more complicated. So TMA is being classified into primary and secondary TMA. I find this chart very interesting and it can help us in remembering what are the possible causes for TMA. So TMA, we've got primary and secondary. If you look at each column, let's focus on the top. This is a primary TMA. It means that the TMA happenings not related to other illnesses. Okay, so we can have hereditary primary TMA or acquired. The acquired form of primary TMA will be our TTP because of the autoantibody. Then the AHUS. This is the one on the left upper quadrant is basically the primary TMA hereditary form. So we have congenital TTP here. We have many genes in controlling the regulation of the complements. So we have AHUS with complement gene mutation. We got DGKA TMA. We got cobalamin C deficiency mediated TMA. Okay, so this is primary, not associated with other illnesses. On the left hand is hereditary, on the right hand acquired. So if we look below here, this is secondary TMA, is association with a second disease. Can broadly divided into infection associated. So we have the E. coli, the sugar toxin producing E. coli HUS, pneumococcal HIV associated TMA. The other group is being grouped under the secondary TMA. We have pregnancy-related health and also pregnancy-associated TMA. We have glomerular diseases causing TMA or your glomerulonephritis. We got malignancy-associated TMA. We have TMA with severe hypertension, transplant causing TMA. We got drug-induced TMA and autoimmune diseases causing TMA. So I find this chart very useful in memorizing all the possible causes for TMA. Okay. If we talk about histopathology, when we have so many causes for TMA, apparently different pathology is a culprit for different TMAs. For example, in TTP, the von Willebrand platelets aggregates is the one causing the thrombosis and luminous stenosis, later thrombocytopenia and MAHA. In DIC, the fibrin platelet thrombi is the main primary event. In microangiopathy happening in sugar toxin, complement dysregulation, SLE, scleroderma crisis, the microangiopathy is the main event causing the MAHA and thrombocytopenia. And don't forget about the tumor cell as well. And depending on the site of organ involvement, it can cause systemic manifestation for this is again another pathology describing the primary event for different type of TTP. So we got von Willebrand factor thrombosis, we have fibrin thrombosis, we have thrombotic microangiopathy, we have vasculitis, we have intravascular tumor cell. Okay, so the example are listed below here. It also this is we can always tell ourselves that these are the conditions that might come to us with bleeding and thrombosis at the same time, like TTP, DIC, HIT, our PNH, our HUS, so on and so forth. Okay, so to diagnose of TTP, I think is quite, from experience, we can kind of rule out TTP. Let's say I'm seeing a patient with very high BP, then with the control of blood pressure, the thrombocytopenia and MAHA gets better, and the patient is rather well. So most of the time we can say that the MAHA is due to the malignant hypertension. And also, let's say we have a patient with septic shock with obvious source of infection, with coagulopathy, with low fibrinogen, high D-dimer. So probably the DIC is the explanation for the MAHA and thrombocytopenia. A vitro level will help us to diagnose for vitro deficiency, which is also mimical for TTP. Positive DAT test for Evans syndrome. And I think for other differential diagnosis, a good history, taking physical examination and targeted investigation can sometimes, most of the time, help us to differentiate the differential diagnosis from TTP. So what if we cannot rule out TTP? We send ADAM-TS13, but please do not wait for the result. Let's treat as TTP because without treatment, TTP mortality can be as high as 90 to 100%. Okay. Here comes the last part of, and also I would say the main part about the presentation, which is how we treat TTP in acute setting. When I was preparing these talks, I basically go through the main 3 DDB guidelines. So when I was a medical officer in trainees, we talk about the British Journal of Hematology guidelines on the diagnosis and management of TTP and other thrombotic microangiopathy. This was published about 10 years ago. Okay. After 5 years, Japanese team came out with a guideline on diagnostic and treatment guideline for TTP that was in Japan. And recently, last year, ISDH came out with a guideline for treatment for TTP, in which they came out with 11 recommendations. So ISDH is our International Society of Thrombosis and Hemostasis. So we'd like to talk about this ISDH guideline and to incorporate that into our clinical practice. Okay. The 3 main pillars for TTP management, we can't run away from daily TPE. This is therapeutic plasma exchange. We need immunosuppression. We need a new medication called carfilzomib. So a TPE plasma exchange, as we remember, in TTP, we have very sticky ultra-large bond-relevant factors. So we need to remove them. We need to remove the ADAM-TS autoantibodies, and we need to replace the functional ADAM-TS so that we don't develop further microthrombi. Okay, so we need daily TPE. We need immunosuppression like steroid plus minus rituximab in suppressing the overactivity of the immune system. And we have a new thing called carfilzomib, which is an anti-bond-relevant factors, which cause immediate blocking of binding of bond-relevant factor to platelets. This was shown to reduce exacerbation and reduction in TPE. Let's go through one by one. Okay. Before that, this is the ISDH recommendation published last year. It's a very busy table. Basically, let's look at the green color box, which indicates the action to be taken. Okay? So if you have a patient that we suspect this is a TTP with high, more than 90% pre-test probability of TTP, okay, we start therapeutic plasma exchange and steroid. Do not wait for the result to come back. Okay. Then the algorithm is divided into 2 pathways. We'll ask ourselves whether we can get the ADAM-TS 13 activity result within 72 hours or within 7 days, or we can only get the result probably after 1 week. Okay, so this is the main 2 pathways. Okay, let's look at the right hand side. Most of the time, for example, we can't get the ADAM-TS 13 result within 1 week. But patient is very, clinical picture very suggestive of TTP. You have started plasma exchange and steroid. You do not add carfilzomib because we don't have ADAM-TS 13. You consider rituximab. I understand that previously rituximab we only used in severe TTP, but from this ISDH guideline, it suggests that if you have very suspicious case of TTP, you give TPE, steroid, and rituximab. Okay, on the left-hand side, basically is ADAM-TS 13 activity guided treatment. When we have very high pretest probability of TTP, and we think that ADAM-TS 13 result can come back within 7 days, you add carfilzomib while waiting for the result. Okay, so number 1 is for TPE steroid, number 2 is for carfilzomib. And let's say we have confirmed the diagnosis of TTP. So with the plasma exchange, steroid, carfilzomib, then we add rituximab here. Then if the activity is more than 20%, meaning that this is unlikely TTP, so we stop the Plasmid and consider other diagnosis. What if we have a borderline ADAMTS13 level about 10 to 20? Okay, so this we need to use our clinical judgment, and we need to continue to ask ourselves, does this patient fit the diagnosis of TTP? Can it be other differential diagnosis? And we understand that we do have case study and case series presenting TTP case with the ADAMTS 13 level of borderline, which is 10 to 20%. Okay, so this is an algorithm for patient with high pretest probability of TTP. So what if it's only low and intermediate pretest probability of TTP? Again, on the right-hand side, let's say the ADAMTS 13 result will not be available within 1 week. We do plasma exchange steroid. We do not add Plasmid. Okay. What if ADAMTS 13 is will be available within 1 week? Because the pretest probability of TTP is either low or intermediate, we also do not use and do not start Plasmid until the result is come back. Let's say we have confirmed that this is a TTP case of activity less than 10%. So we give the patient TTP, TPE, steroid, we add Plasmid, we add rituximab. Okay. So if activity is more than 20%, we consider other diagnosis. If 10 to 20%, again, we use clinical judgment and we consider other diagnosis. So these two are the algorithm from ISTH guideline for the TTP published recently. This is a summary of the ISTH DTP management. When the patient has very high pretest probability, and if we can get ADAMTS result timely, we do plasma exchange, we give steroid, we give Plasmid, and later our management will be guided by result of ADAMTS 13. Rituximab for confirmed case. For borderline or negative cases, we use clinical judgment and stop Plasmid. If ADAMTS is not going to be available soon, we give, and the patient is very suspicious of TTP, we do plasma exchange, we do steroid, we give rituximab. Even the ADAMTS result is not available yet. Okay. So for low or intermediate pretest probability, you see here the Plasmid doesn't come into the algorithm for low and intermediate case. We do plasma exchange and steroid, and also the later treatment is basically guided by the ADAMTS 13 result. If confirmed case, we give Plasmid, rituximab. How about other ADAMTS level? We need to consider other diagnosis. All right. So let's talk about the 4 components here: plasma exchange, steroid, rituximab, and Plasmid before we end our talk. Okay. This is a landmark trial published in 1991 comparing TTP patients who received only plasma infusion versus plasma exchange. You can see it very clearly that the surviving overall survival curve separated out very nicely. So from this landmark trial, we recommended plasma exchange for all TTP, but not only plasma infusion only. So we start the patient with 1 to 1.5 plasma volume exchange with TTP. We do daily until clinical response. Okay, clinical response means sustained normalization of platelet above the lower limit. Most of us will take 2 readings of more than 150, and the LDH is less than 1.5 upper limit of normal. Okay, again to remind you why we do plasma exchange. We want to take out the ultra large von Willebrand factor, which is a culprit for thrombosis. We want to remove the antibody, which is a culprit for TTP, and we want to replace with the normal plasma the functional ADAMTS 13 from the donor plasma. Okay, this is about TTP. Photo point of view, we have 1 out and 1 in. So the patient bloods will be drawn to a plasma filter. Our plasma machine is usually in hematology, we use a TIA machine. So basically the concept is your whole blood inside the machine is being centrifuged. So the centrifuge will separate your blood component to few layers depending on the size of the blood product. For example, packed cell, red cell will be lower at after centrifuge. It will be, because it's heavier, it will be lower down in the system. Then top will be the plasma. You see here the unwanted plasma will be removed. Then you replace with the donor FFP or donor plasma back to the patient to replace the functional NTS. Okay, so this is the concept for plasma exchange. I received many calls about how many volume to do. We have basically about 3 ways in calculating the volume. If you remember that our blood volume is the weight multiplied by 55 to 75 ml per kg. This is the total body blood volume for adults based on the Gilger's rules of 5 for blood volume. You can see that male, female, fat, thin, normal, or muscular patient has different ml per kg for their blood volume. Let's say we are seeing a 70 kilo patient male. So let's say male 70 normal. So I'll take 70 ml per kg. So the blood volume for this 70 kilo gentleman is about 4.9 liter. Then the plasma volume is blood volume, which is 4.9 multiplied by 1 to minus hematocrit. Let's say the hematocrit is 40. So the blood volume here is 4,900 multiply 1 minus 0.4, which is 0.6, and you will get 2.94 liter. Okay, so this is a formula that you need a patient weight, you need a patient hematocrit, and also remember the Gilger's rules of 5 to calculate. A very simple way, sometimes we use 40 ml per kg for all adult cases. If you follow this calculation, I take a patient of 70 kilo, I will get 2.8 liter. Okay. If you want to follow Kaplan's formula, our very famous 0.06 multiply body weight multiply 1 minus hematocrit. Okay. Let's take the same example. Same patient, 70 kilo, hematocrit 40%. I will get 2.73 liter. Okay. So 2.9, 2.8, 2.73. I think it won't be wrong that, let's say we decided to plasma exchange about 3 to 4 liters of plasma for all adults in general. Most of the time, you can't be wrong. But this is how we formulate the volume needed. Okay. British Journals of Hematology, the paper on guideline and the clinical use of apheresis procedure for the treatment of patient and collection of cellular therapy products recommend that in TTP or atypical HUS, we use FFP. This is solvent or detergent treated FFP in UK. Okay. We need to treat the DTP or atypical HUS as emergency. Let's aim to initiate plasma exchange within 4 hours of presentation. Okay, this is our aim. And again, we do daily plasma exchange until the platelet is normal for, they suggest 3 consecutive days. Then let's say there's no response, you increase your to 150% plasma volume until there's a response while waiting for the other medication to work. All right. How about steroid? I always ask myself about a steroid dose in TTP. If I'm seeing a case of TTP, I will ask myself, is this a standard risk TTP or is this a high risk TTP? Okay. So from one, we can find few papers online defining the severity of TTP, in which the indicator for mortality in TTP in this group of patients is very high. So they say with the presence of these symptoms, we can say that patient is having high risk TTP. Okay, age of more than 60, severe CNS involvement of seizure, focal weakness, aphasia, dysarthria, confusion, and coma, and high LDH level of more than 10 of the upper limit normal indicates multi-organ involvement, and also waist troponin level of more than 0.25 microgram per liter indicates high-risk TTP. Okay. So if high-risk TTP, guidelines suggest we use metapred 1 gram daily for 3 days, then change your prednisolone to 1 milligram per kg and taper accordingly. Or we can use metapred of 1 to 5 milligram BD, TDS, or QID per day for 3 days, then taper to prednisolone 1 milligram per kg. Otherwise, a standard risk TTP, we use prednisolone 1 milligram per kg. we need to pay special attention to the side effect of steroid. Let's say this is a hypertension patient with diabetes mellitus, psychiatric comorbidity, or advanced age. Bear in mind that very high dose of steroid might cause a lot of complication, especially in this group of patients. Okay. What about patients who cannot tolerate orally or be worried about the absorption? In fact, an intravenous route of a steroid, which is equivalent to prednisolone 1 milligram per kg, is being used as well. Okay, so we have gone through TPE, plasma exchange, steroid. Now comes the rituximab in TTP. This is the latest ISTH guideline, that the 11 recommendation that I mentioned to you. Rituximab came out with recommendation 2, 4, and number 6. If you can see the green bar here, in immune TTP first event, with addition of rituximab to steroid and TPE over steroid and TPE alone. So meaning that in first event, we add rituximab. Okay. So what if relapse cases also they recommend addition of rituximab to steroid and TPE. Okay. What if ITP in remission, but when we monitor the ADAM-TS activity, they have low ADAM-TS activity. So the guidelines suggest rituximab as well in the TTP. I didn't write down the dose of rituximab here. Conventionally, we use 375 milligram per meter square weekly, but there are papers talking about rituximab lower dose, 100 milligram weekly for 4 weeks. And the timing of giving rituximab is important as well. Let's say we're doing TPE plasma exchange daily. So the rituximab need to be given after the plasma exchange so that we don't exchange out the rituximab. Okay. So this is about rituximab evidence, which appears to prevent delayed relapses in ITP. The graph, the y-axis represent the relapse-free survival. The table A, the figure A and figure B. The A is observational study up to 25 months, but B, when we extend the study to 5 years. Okay. When we look at A, the relapse-free survival at 2 years significantly higher in rituximab. So the top is actually those patients who receive rituximab. Then the relapse-free survival is in fact significantly higher if compared to patients who do not receive rituximab. But let's say we extend the study up to 5 years. Apparently, the incidence of relapse at 5 years did not differ between the two groups. Okay, so it's very important for the first 2 years. Okay, the last medication that I would like to introduce, which is plasmid in immune TTP. In short, this is called anti-von Willebrand factors. Remember that our ADAM-TS13 cut at A2 domain. Okay, so plasmid target A1 domain. A1 domain, from one of the picture that I show, is actually the site where platelets bind to von Willebrand factor at A1 domain through the GP1B receptor on platelets, right? Okay. So when we use this plasmid, the red color medication on the von Willebrand factors, the platelet cannot bind to the von Willebrand factors. So you have no thrombosis. Okay. So this is targeting A1 domain of von Willebrand factor that interact with platelets to prevent formation of microvascular thrombosis. It needs to be given from the very beginning because the thrombosis is very significant from the very beginning of TTP. This is a phase 3 landmark trial for plasmid. It's called Hercules trial. The conclusion from the trial shows that with the use of plasmid early, we have faster normalization of the platelet counts, meaning patients who receive plasmid, the platelet counts become normal using 2.69 days versus 2.88 days in the placebo group. Okay, significantly, patients who receive plasmid has fewer therapeutic plasma exchange, so they only need about 5.8 cycles versus about 9.6 cycles in the patient who receive placebo. In plasmid group, they have fewer exacerbation in 30 days after stop the plasma exchange, which is 12% of them have exacerbation, meaning that the platelets drops again within 30 days. However, in placebo group, we have 38% of patients who experience exacerbation of the TDP after stop TPE. Okay, and I think this is quite significant as well, in which in the papacyzumab group, the hospitalization days is about 9.9 days versus 14.4 days in the placebo group. However, as we know, it blocks the A1 domain, so platelet cannot bind to thrombin factors. So, but I was asking myself, are the patient high risk of bleeding? The answer is yes. We have more bleeding, 65% versus 48% from the Hercules trial. However, the author and also the investigator noticed that most of the bleeding are mild to moderate, in which it can be managed symptomatically, and no major bleeding has been seen, if I'm not mistaken. Okay, so I hope I have covered the learning objective for today, which is a clinical lab presentation for TTP. We use French and Plasmid Score to differentiate TTP from others. We gone through a whole list of TMA, the thrombotic microangiopathy, as a differential diagnosis, and the mimickers, and how do we treat TTP. Am I overrun? Okay, so this is my last, okay. Sorry, Dr. Lim, few more, one more slide. This is our Ampang forms, okay. And I highlight to you that we sent Adam TS13, the whole Malaysia is sending the hospital Ampang to the hemostasis lab, Adam TS13 activity over here. DTP doesn't decide to come, most of the time they come middle of the night. So if you have a case, fill up this form signed by a specialist, and usually I call our lab colleague, and they need to help us. We need two citrated tube, then we need double spin, okay? So so that they can keep the sample before, so that we can proceed with our plasma exchange or even plasma infusion. We do not wait for the weekdays only we send the identity as the team. So this is what I would like to share with you. This is the last slide, the timeline for the key events in TMA. We got Dr. Moscovitz here. We got 1998, only we found identity as the team. So that's all, Dr. Lim.
Thank you very much, Elaine, for your very comprehensive and informative talk. Before I go to the Q&A, I just want to add on for the Plasmid Score. Just now, what Dr. Gunn showed is the unit that used in the US. But if you put it to the unit that we use, the indirect bilirubin of 2 mg per deciliter will come up to about 35 of our usual micromole per liter. Whereas the creatinine of 2 mg per deciliter will come up to about 175. So it's a scoring system that may be useful to help us to decide whether this is a likely TTP, and a score of 5 to 7 is highly suggestive. So we go on to the questions here. The first one is, what's the level of cystocyte? As you all may know, the cystocyte, when it's reported, it can be how many cystocytes per high power field or percentage. Elaine?
Yeah, hi, Dr. Lin. I realized that last time we used to do like every few days we repeat blood films, basically to look at the number of cystocytes to decide whether this patient is clinically getting better, or we need to increase the frequency of therapeutic plasma.
Sorry, the question is to make the diagnosis.
Okay, I think we need to make the diagnosis. I have looked through into the literatures that they suggest that more than 3 to 5% of cystocyte in blood film is suggestive of DTP. But lower than that, but I do not use cystocyte percentage, Dr. Lim. We go clinically, we look for MAHA and thrombocytopenia. In fact, I don't think there's a black and white number that say how many percent cystocyte is suggestive of DTP. What is your opinion, Dr. Lim?
Yeah, some literature quote 2%, but But that brings up one case that was in Sagama a few years ago. Patient came in with thrombocytopenin and anemia. The first TBF, only a few cystocytes seen, and they actually missed it. They just transfused and discharged the patient. 2 weeks later, came in with the frank TTP, and that's when I told the hematopathologist who looked back and said, yeah, there is actually quite a significant amount of TTP. So I think the learning point from this is that if you suspect it's TTP and the first one is still not suggestive, please do not hesitate to send another one in another 3 to 4 days time. And if you see an increasing cystocyte, then you must call us out. Okay, second and the third question I'll combine together. I think the second question, there's probably a typo error. Whether you prefer to use FFP or cryosupinated for the plasma exchange.
So far, I think we have only head-to-head compared trial comparing cryoprecipitate poor plasma, which is cryosupinated versus FFP. In fact, the trial is rather small. One trial is only about 52 patients, another trial about 17 patients, and there's no difference in using both either FFP or cryosupinated. So yes, I myself both use plasma.
I remember when I first started, I tried to get the cryosupinated, but you know, if you want that, you need to call up the blood bank in the early morning, ask them to call the cryoprecipitate, and then only you get it. For those who don't understand, is cryosupinated has reduced level of fibrinogen factor 8 as well as the von Willebrand factor. So theoretically, it may sound a better fluid exchange, but in actual, it does not differ. So just go ahead with FFP you will do. The next question is, yeah, sorry.
Dr. Lim, I think probably another point, let's say we're using cryosupinated because we need to monitor the coagulation and fibrinogen regularly as well.
Yeah, otherwise they become depleted and they develop bleeding tendency. The next question is, whether in a true TTP, will you get an abnormal coagulation profile to differentiate from other differential diagnoses?
I suppose in TTP, a pure TTP, we do not have coagulopathy if compared to others like DIC, sepsis, and other cases. Yeah, that's why in Plasmid Score, the NR of less than 1.5 is score 1. Yeah,
that's right. The next question is whether you do give TTP, plasma exchange steroid on the same day, and whether you do a plasma exchange on daily or EOD basis.
I think quite straightforward answer. We do on the same day, concurrently. If possible, start TPE within 4 hours. Yeah.
Yes, yeah. I have to say that bring up to my experience of mine previously where I delay because if you work in a very busy center, you're alone, you have a delay in doing the plasma exchange, patient can actually just have a sudden death on you. So if you suspect a TTP, please call up a center with hematologists as soon as possible and get the patient to go there. But while waiting, you can actually consider giving an FFP infusion. That brings up the next question, whether a transfusion of blood and blood product prior to TPE. I think I sort of answered that one already. You can use a FFP infusion if you can't offer the TPE. In the post-AZ COVID vaccination, how to differentiate VITT from the usual TTP?
Dr. Lim, you want to answer? I think it's very difficult.
Yeah, it's actually a very different things altogether. In the true VITT, you don't get the cystocytes, whereas in your TTP, you get the cystocytes. So next question, do we maintain monthly retux after a month of weekly dose initially?
No.
If yes, how long? No. Yeah.
No, we don't.
How long should we keep the prednisone as maintenance after the acute event? So how long do we treat with prednisolone?
Dr. Lim, I think from this recommendation guideline also, let's hope to taper off steroid, let's say within 3 to 4 weeks. Then again, based on the clinical response from the patient, then only we taper off and taper down the steroid. So there's no guideline to say so because every patient is different. We need to go clinically.
Yeah, I agree with you. So what happens is when we do that, we have to tell patients there's about 10 to 20% chance that they will recur, and they already know from their first presentation what are the clinical symptoms. So tell patients, if you have this and this and this and this, please quickly come and see us. Last one is talking about caplacizumab, and do we have it in the park? Well, unfortunately, I don't think, this drug is available yet. How frequent do you send the PDF, and how do you do the monitoring when the patient on plasma exchange?
Okay, most of the time, the reason I send blood film is to confirm the true thrombocytopenia. Because sometimes the platelet counts are inaccurate, especially when they count the very small cystocyte into the machine. So it's actually to confirm, but I won't really depending on the percentage of cystocyte to guide my treatment. So usually I do weekly.
It's sort of a bit delayed. So actually you can other things. So the rise in platelet count, the HB become improved, the drop in LDH, all these are useful. There's another question come up in the chat box, whether the platelet transfusion is contraindicated, and when will you consider this transfusion if the patient have bleeding?
This is to answer Lai Chi, our trainee from Ampang. Most of the time, TTP patients don't bleed significantly. Okay, platelet count of 20 is in fact safe enough from BGH guideline to put in a venous catheter for plasma exchange. Two conditions need to be there: an experienced staff, an experienced doctor, ultrasound guided. So platelet 20 should be good enough. Unless other significant bleeding, only I will give platelet transfusion.
I still remember my first patient here 10 years ago. She was diagnosed as so-called ITP in private. The private physician give 4 unit platelet, immediately patient has a seizures. Came here, treated. Some years later, developed ICB. That's when I actually give the patient develop ICB from other reason. That's when I give 4 unit of platelet. Any other questions? I think we sort of answer all the question already. Dr. Mina, I want to stop us already, is it?
It's 401.
If I can just add in a few that I remember from my past year here. One is, do like what Dr. Gan said, do try to look for some secondary causes if your patient not responding to plasma exchange. I have 2 patients here who turns out to be HIV positive. I have 1 surgical MO, unfortunately actually have a metastatic undifferentiated gastric CA, and he passed on a few months later. So all these conditions can actually mimic the TTP. Also is, nowadays there's so many hematopathologists everywhere. So if you have a suspicion, after you send a PBF can be read within the next 1 hour. So please call them up and tell them this is urgent and you need to refer to a hospital with hematology as soon as possible. Question is, would you consider upfront retux in all cases of TTP, Elaine?
Yes, according to the latest recommendation for ISTH, for very high retest probability of case of TTP, they use rituximab upfront.
But having said that, cost is an issue. 1 valve is still about 3,000, so you give 4 valves, it's still about 12,000 ringgit. But of course, we can consider a lower dose, like Elaine said.
It causes financial toxicity to the center.
We sort of reserve to refractory cases only be used here. Any more question, Mina, you can see?
No, I think that's all.
The transfusion platelet we already covered already. I exceed the time a little bit, but have to say thank you very much to Elaine. You have presented very well, very comprehensive, up to date. And thank you very much to Dr. Mina for organizing this event.
Thank you.
Any last word from you, Dr. Mina?
Thank you very much, Dr. Lim and Dr. Gan, for such an informative talk. And I think we had very good practical questions from the participants as well. So we know that everyone has, it was a very beneficial talk to everyone. So thank you very much. I want to take this opportunity to tell all the participants that this is the final week for hematology. Next week is October, and so a new month, and we will be starting with COVID-19 topics. Just for October, we are focusing on COVID-19. So the lineup we have is, we'll start off with update on the COVID-19 management. guideline, the one we had recently, and then followed by a role of ultrasound, lung ultrasound in COVID-19. Then we will talk about the respiratory complications in post-COVID patients. And subsequently, we will end with vaccines and all the myths, and we'll have like a forum talk. We have 4 panelists that we have invited for that as well. So please share with everyone, and so hope everyone can benefit from that as well. So thank you very much again, Dr. Lim and Dr. Gan. Thanks a lot.
Thank you very much.
Thanks, Dr. Lim.
Nina.
Okay, thanks. Bye.
Bye. Thanks.